Student Forum for the Medical Student Research Program. The program is supported by the National Institutes of Health, the Heart, Lung, and Blood Institute. Other aspects of the program are supported by other institutes such as neurological diseases and stroke and childhood and human development. We're going to get started with this summer's program, and I'm going to ask you to come up in order. That way I don't have to announce you, because you're going to have your name up there and your mentor. If any of you have a special time that your mentor needs to be here, make sure we adjust the schedule accordingly. Okay, so just get started and come up in order, and make sure that you have your pre-questions and your post-questions. Thank you.
Okay, I can get started. All right. Hi everyone, my name is Krishna Bavaria, and today I'm going to be talking about anal cancer screening for people with HIV in Southern Arizona. And my mentors were Dr. Lori Bantry and Dr. Arti Pandya. So a little bit of background information about my project. I think it's important to establish that HIV is a strong risk factor for anal cancer. And if we look at the figure on the right, we can see that the men that have sex with men population compose nearly half of the HIV population in Arizona for several decades now. Also, in 2022, there were roughly 20,000 people who were living with HIV or AIDS in Arizona, and the American Cancer Society predicts that nearly 10,000 people are going to be newly diagnosed with anal cancer, and 2,000 deaths are going to occur as a result of anal cancer. Despite all of this, there have been no studies performed on anal cancer screening in Southern Arizona. So on this slide, I've listed the risk factors for anal cancer. However, for our study specifically, we've looked into the men that have sex with men population and the HIV positive population. So HIV is strongly associated with high squamous cell intraepithelial lesions, which does have a high risk factor for progressing to anal cancer. So that's why we've chosen these two demographics to look at for our study. So my summer research project question was, are HIV positive cisgender women, transgender women, and men who have sex with men communities in Southern Arizona being adequately screened for anal cancer per the new updated New York State guidelines? The goals of our study, we have 4 specific goals. The first of which is to determine the percentage of people in that specific community in those specific communities who have had anal paps in addition to digital rectal exams annually or ever in their life. Of that population, we wanted to determine how many of those anal paps resulted in dysplasia. Of that population, we wanted to see how many of them decided to proceed with a high-resolution anoscopy or an HRA. And then of that demographic, we wanted to compare the results for the anal pap and the HRA. So the basis for our study was the ANCHOR study. This was a very large clinical trial that ultimately showed that individuals with HIV who had HCEL or high squamous cell intraepithelial lesions, that when those individuals were treated, it reduced their risk of anal cancer by over 50%. It also showed that of the individuals who had anal cancer, 44% of them had missed not only screening opportunities for anal cancer, but they also missed treatment opportunities as well. On this slide, I've included a figure that outlines the New York State guidelines, or the updated ones. So to understand this, we're looking at our target demographic, which are HIV positive individuals who are over the age of 35 who have had an anal pap. So based on the anal pap results, you can fall into 3 different categories. You can have normal cytology or ASCUS. ASCUS is atypical squamous cell of undetermined significance, or you can fall into higher low-grade squamous cell intraepithelial lesions. So taking those 3 categories and factoring in their HPV status, it determines whether or not they end up proceeding with an HRA or the high-resolution anoscopy. The reason that an HRA is a very specific and sensitive test for detecting high-grade dysplasia in comparison to an anal pap, which only has a specificity of only 50%. So currently we are still very early in the process. We're still in the data collection process. but we have been able to review nearly 300 cases. But through this data collection process, we have been able to make preliminary observations, including that many individuals who meet the New York State guideline criteria are unfortunately not being screened for anal cancer. There are a couple barriers to people undergoing or having limited, there are several barriers to accessing their care, one of which is that the nearest HRA qualified surgeon is located in Phoenix, Arizona. So this could provide transportation issues, cost issues, or issues with getting off of work. However, there are programs like the Ryan White Foundation, which not only provides funds for the actual treatment or the actual procedure, but it also provides funds for transportation to Phoenix and back. In addition, like I mentioned previously, the anal pap only has a specificity of 50% when predicting the severity of lesions. So it's not, while it is easier to perform in clinic, it is more accessible for a lot of patients. It's not the best test in determining whether or not people should continue to have anal cancer screening or whether or not they should proceed with an HRA. This is because we've had when reviewing cases, we've had several patients who the anal pap shows more of a benign lesion, but the HRA shows something a bit more concerning. In addition, prior to the anchor study and this study, there's very limited evidence to help supply the information for an updated guideline. So we are still learning more information on how to provide better anal cancer screenings. So questions that we have remaining or that arose from our study include determining the value of anal paps. So, like I mentioned before, the results from anal paps may not be the most specific in comparison to an HRA, and as a result, it may lead to impaction of care and may impact whether or not someone continues to be screened for anal cancer. In addition, we would like to determine how limited access to HRAs in Southern Arizona impacts care, because even though there are programs like the Ryan White Foundation, there's only a small demographic of people who fall into that category, including those who are of low socioeconomic background, in addition to those that are uninsured. Finally, this is a more holistic question, but we want to learn more about how we can improve anal cancer screening for the HIV population as a whole. So that's the end of my presentation, but I'd like to give a special thank you to my mentors, Dr. Fantry and Dr. Funya, who unfortunately could not be here today. And these are my references. And then I left room for questions if anyone has any. Yes?
What's the difference from the high resolution anoscopy and colonoscopies?
That's a really good question. So from what I understand, there are two different scopes completely. Colonoscopies generally just look at the colon, as opposed to the anoscopy, which is it's better equipped for looking at mucosal damage in the anus and the rectum. And I think the differences between it is the type of lighting and the type of resolution that they have. Because if you were to do a colonoscopy, I don't think the way that it's just not as sensitive for looking at those kinds of lesions. In addition, colonoscopies are generally performed by colorectal surgeons or GI specialists, but the anoscopy can be performed by just anyone that's certified, including, it's primarily done by colorectal surgeons, but it can be gastroenterologists, infectious disease physicians, gynecologists. You need the training for it. But there aren't a lot of people that are specialized in it, which is why we send our patients to just one provider in Phoenix. A good question.
Early on in the epidemic, when Kaposi sarcoma was common, it also occurred in the anus and rectal area. I wonder, now that it's almost non-existent, is it still occurring? Have you come across any cases of Kaposi sarcoma among the anal cancers?
That's a good question. I think I saw one case of it, but from what I remember, it wasn't really talked about in the note. They were mostly looking at the dysplasia, but it's truly not as common. I haven't reviewed many cases that had Kaposi sarcoma.
name is Matt McGraw, and today I'm going to talk about new proteins and GLUT4 translocation. And my mentor is Dr. Paul Inglis. So a brief outline of what I want to talk about today. First, I want to talk about GLUT4 in kind of a general context, give some light to what that means. Then I want to talk about the protein that we were studying specifically in relation to GLUT4, then go over some of just general data that we found, and then some next questions based off the initial questions I have. So to start us off, let's just think about food and how we break down food. So hopefully all of you had breakfast this morning. If not, think back to yesterday when you ate. Eventually that food was broken down into glucose, and then this glucose will eventually enter our beta cells. And what happens is our beta cells, via an enzyme called glucokinase, will break down this glucose into ATP. The rise in ATP levels will then allow for insulin to be secreted from these beta cells, and then this insulin will eventually travel to two main types of tissues, our adipocytes and our skeletal muscle, via the insulin receptor tyrosine kinase. Once it hits that, there's a big series of intracellular reactions, and eventually GLUT4 will make its way from around the cell to the cell membrane. At that point, glucose can actually be transported from outside of the cell, inside of the cell, so we can use it for energy via ATP. And biologists aren't the most creative on the planet, so GLUT4 literally means glucose transporter 4. Right in the name, takes this glucose and transports it through the cell membrane into our cells. So what we're really interested in is what's happening inside of the cell to cause this GLUT4 to actually make its way to the cell membrane. And specifically, we're interested in what's happening right before that GLUT4 actually makes its way over. So to kind of zoom in on this part of the process, this is a little schematic of what that might look like. So we all know about the cytoskeleton, and there's something called microtubules, and these are composed of alpha and beta tubulin dimers, and these will come together and allow for us to move things across the cell, and GLUT4 is no exception. So this is a glucose storage vesicle, and that will hold a lot of GLUT4 around its membrane. And I think of it as a track race. You're kind of handing off the baton. So the microtubules will bring the glucose storage vesicle pretty close, and then the actin will then take over, grab that baton, and allow the GLUT4 to fuse with the membrane. So this brings us to the protein we were studying, which is called TAC1. So TAC1 stands for transforming like growth factor beta associated kinase 1, also MAP3K7. So what TAC1 mainly does is activate alpha TAC1. And alpha TAC1 is what's called a microtubule acetyltransferase. This is just a fancy way of saying it will modify these microtubules to make them a little bit more stable and less likely to break apart in something called catastrophe. We want these microtubules to stay stable so that we can allow things to move throughout the cell, in this case, those glucose storage vesicles. So this microtubule acetyltransferase stabilizes the microtubules. What's interesting is my PI found that insulin action will actually also stabilize microtubules. So we assume there should be some link between alpha TAC1 and insulin signal transduction. But what's also important is something called TNF alpha. And TNF alpha is also activated. And when it's activated, it activates TAC1. And TNF alpha actually already has a really well-known role in insulin resistance, which can be a precursor state to type 2 diabetes. So TNF alpha levels are elevated in people with insulin resistance, and it's a known cause of that insulin resistance state. So our general hypothesis was that TAC1 inhibition would actually decrease insulin-stimulated glucose uptake via a decreased microtubule stabilization. And this leads me to my initial central question, which is, does TAC1 actually affect insulin-stimulated glucose uptake? As we were doing some initial preliminary work, we found that not only was there changes in the insulin-stimulated state, but there was also changes in the basal state with no insulin stimulation. So this caused me to modify the question a little bit and say, does TAC1 affect GLUT4 translocation in general, not just insulin-stimulated GLUT4 translocation? So I want to give some context to this by showing you some of our data. So what you're seeing here is what's called a radioactive glucose uptake assay. What you're seeing on the x-axis is all of the different conditions that 3T3L1 adipocytes, so fat cells in a dish, were exposed to. In the blue, what you're seeing is the basal state, meaning no insulin stimulation, and then after 15 minutes of insulin stimulation. So this is just a standard that you would normally see, which is with no insulin, you have some amount of glucose being taken in the cells, and then after you give them insulin, that's going to increase the amount of glucose these cells will take up. What we have here in all the other colors are different concentrations of what's called 5Z7-oxazenol, which is a chemical inhibitor of this TAC1 protein. And what you can see is a dose response, meaning the more inhibitor, the higher concentration we use, the less insulin-stimulated glucose uptake we're experiencing. What's also interesting is, in this experiment specifically, we saw an increase in the basal uptake relative to the negative control with no inhibitor of TAC1. Unfortunately, with science, right, things always don't go as planned, and we did a similar experiment, but this time, instead of using a chemical inhibitor of this TAC1 protein, we actually used siRNA. And our logic behind this is we want to make sure that what we're inhibiting is actually what we're targeting. And what you can see here is, instead of having an inhibitory effect like we saw before, now we're not seeing a statistically significant difference, and if anything, it's actually showing a little bit more of a stimulatory effect on insulin-stimulated glucose uptake. So this caused me to change my question once again, and now ask, is 5Z7-oxazenol, aka that chemical inhibitor of TAC1, specifically inhibiting that protein in adipocytes? So it's going to be a long process to figure out how we're going to answer that question, but this is kind of showing a general outline of what we want to do in the future. So in addition to doing these glucose uptake assays, we also want to test this in multiple different ways, meaning we want to use immunofluorescence to actually visualize GLUT4 and see how it's changing in response to inhibition of this protein. We also want to look at caspase-3 activity, which is a way for us to measure apoptosis and see, is the effect we're seeing the result of the cells dying, or is it actually specific inhibition of this protein? And of course, with a lot of research, there were some limitations. One issue is the stock of the inhibitor we were using initially was made in one lab from a collaborator at U of A, and then we ended up making our own stock, and we were seeing slightly different results. Like I said, we didn't account for apoptosis quite yet, and also TAC1 may affect more than one protein in GLUT4 translocation, so we need to figure out better ways to parse that out. And then lastly, I'd just like to thank everyone in my lab. Starting out with all of the lab techs who joined us this summer. It was a pleasure to teach them and to have them collaborate with me, and by the end to actually watch them do all of these complicated assays. It was super cool to see. Our grad student, Emily, she is absolutely incredible. And of course, my PI, and then Austin, who's the king of jokes in our lab. Yeah, thank you so much, and if you have any questions, I'm more than happy to take them.
Can you give me 2 minutes? I'll be right back. So just get ready to do your next presentation. Okay.
And then just some references.
And today I'll be talking about how CMP miR-146A targets inflammation to treat acute lung injury. Here are our disclosures. So the research question I started off this summer with was, what is the optimal dose of CMP miR-146A treatment in reducing inflammation following LPS-induced acute lung injury? So a little bit of background, acute respiratory distress syndrome is the most severe form of acute lung injury. It accounts for around 10% of ICU admissions worldwide, and it carries up to a 40% mortality rate. The pathophysiology involves diffuse inflammation of lung tissue, particularly the alveolar endothelium, which can lead to subsequent lung fibrosis. Currently, there's no specific treatment. It's mostly limited to supportive care with mechanical ventilation. So our lab looks particularly at miR-146A, which is a microRNA. It is non-inflammatory, and it prevents activation of the NF-kappa B pathway. It leads to downregulation of pro-inflammatory cytokines. We look at this particular microRNA because we know that its endogenous levels are downregulated in acute lung injury, And so our thought is that if we are able to deliver this microRNA to a tissue experiencing inflammation, we could perhaps attenuate that inflammation. In order to deliver this microRNA, we conjugate it to serum oxide nanoparticles. These serum oxide nanoparticles have a ROS scavenging role, so when they're conjugated together, they can target inflammation and oxidative stress simultaneously. So our hypothesis is that CMP miR-146A therapy will reduce inflammation and oxidative stress in the LPS-induced acute lung injury mouse model, ultimately resulting in restoration of lung function. In order to test this hypothesis, we used a well-established acute lung injury mouse model. We delivered 50 microliters of LPS intratracheally to cause injury. 4 hours later, we administered 50 microliters of our CMP miR-146A treatment intratracheally. Then 24 hours post-initial injury, we harvest the lungs. From here, we can either do cell staining and histology or PCR. If you go down the PCR route, first you process the tissue by homogenizing it, then you extract the RNA, take it to cDNA, and then finally qPCR to analyze the inflammatory markers. So we found that CMP miR-146A reduces the expression of pro-inflammatory cytokines following acute lung injury. Here we're looking at IL-6 and IL-1 beta relative gene expression levels. On the bottom you can see the control group, the injured LPS group, and then our treated CMP miR-146A group. You can see a similar trend on both graphs where the LPS injured group has an increase in the relative gene expression of the pro-inflammatory cytokine compared to our control group, and then with treatment it is significantly reduced. Here we can see CD45 staining of lung tissue 14 days post-injury. CD45 stains immune cells, so all those brown dots you see are immune cells. You can see that compared to the control, the injured group has a marked increase in those immune cell infiltrates. And then once we add our CMP miR-146A, it's practically back to control levels. This is important because, again, that inflammatory cell infiltrate and the chemokine and cytokine signaling it brings with it can lead to later lung fibrosis. So here we can see that CMP miR-146A improves lung function following injury. On the graph on the left, you can see that the percent change in elastance is increased in our injured group compared to controls. You can think of this as lung stiffness. So lung stiffness is increased with our injured group, and then once we add our treatment, it goes back down significantly. We see a similar trend in the percent collapsed septae, which is just percent collapsed alveoli. And overall, this shows that CMP miR-146A improves mechanical function and parenchymal structure, and we assess this 2 days post-injury. So up to this point, we've been using 1 dose of CMP miR-146A, but we were curious to see if we increase the dose or decrease the dose, whether it would change the efficacy of the treatment. So here we have a dose-response curve. You can see that we looked at IL-6 and IL-8, both pro-inflammatory cytokines, and we can see the similar trend we've been seeing so far, an increase in the relative gene expression in our LPS injured group, and then as we add more CMP in increasing doses, the relative gene expression goes down. It then reaches a plateau. That plateau is at about 1 nanogram per kilogram in our IL-6 graph and 10 nanograms per kilogram in our IL-8 graph. Lastly, we wanted to look at the efficacy of our GLP grade CMP miR-146A. GLP stands for Good Laboratory Practice. It's a set standard of quality control measures, and anything made under GLP can be potentially used for clinical trials. And ultimately, that is where we want to progress with this project. So here we were looking at the efficacy of our GLP grade CMP miR-146A compared to our lab-made CMP miR-146A. And we looked at IL-6 gene expression, and as you can see, both of the batches of CMP miR-146A were able to significantly reduce the gene expression of IL-6. So in conclusion, we found that CMP miR-146A reduces inflammation in the lung tissue by downregulating inflammatory markers in the NF-kappa B pathway. It reduces inflammatory cell infiltrate in the lung parenchyma, which again is a critical component component of the pathophysiology of acute respiratory distress syndrome. It improves lung function and structure after injury, and we found that the optimal therapeutic dose for CMP miR-146A that reduces inflammation the most is 10 nanograms per kilogram. So overall, the benefits of working in the lab the last 2 months were that I gained a lot of wet lab skills. I learned the workflow of a lab, especially one that has many different projects going. I also got to observe and learn a few procedures in the other projects, including our pressure ulcer and diabetic wound healing projects. In terms of future directions, I'm curious about the role of CMP miR-146A on other inflammatory pathways, such as the JAK-STAT signaling pathway. This pathway relies more so, or some of the proteins in this pathway rely more so on phosphorylation for activity levels rather than gene expression. So this would require me to use Western blot, which I'd be interested in learning to further explore this. And also, I'm interested in validating that dose-response curve with LPS, induced lung injury, in addition to the different doses of GLP grade CMP miR-146A, because as I mentioned before, this would be the batch of CMP miR-146A that we would use for clinical trials, which is our ultimate goal. I'd like to acknowledge everyone in the lab for their support over the past few months. Does anyone have any questions?
I'm assuming your future directions are actually your remaining questions, and they
Yes.
have a question mark.
Yes.
after them.
Yes.
Because we have a way of covering things up, when we write grants with all the future directions, when it's actually the remaining questions we have and how we want to approach them. So I think it's important to put that question mark. Yesterday there was a terrific grand rounds in surgery, and Dr. Grander, who I consider knows more about sleep than anyone who's ever slept, put it that way. And the title of his presentation is, "What is sleep?" That sounds like a very obvious answer to the question, but he showed that it's far more complex and so on. So I think it's important to put those question marks. And are there any other questions at all?
What was the most difficult wet lab technique that you had to learn?
Great question. So I came in very fresh. I didn't have any wet lab experience practically, so I really relied heavily on my lab. It's back there. Thank you, everyone. But I mostly did PCR, and for lungs, you have to, it's a little different from the other organs that we use. We have to split them into 2 tubes when you're doing PCR. So if you have 20 samples, it becomes 40 tubes. And so I heavily relied, again, on my lab mates to help me with that, because processing 40 tubes is crazy. So yeah.
Are there any?
How did you dose the miRNA? Was it via an injection, or was inhaling something?
Yeah, thank you. So it's intratracheally. So what you do is you anesthetize the mouse briefly, so they're asleep for 15 seconds or so, and during that time you have to open their mouth and insert a pipette and basically get it into their trachea by that way. Yes.
I don't know if you said this, but at what point did you start dosing after the acute lung injury?
4 hours.
Okay.
Yeah, so acute lung injury, and then 4 hours post we do the treatment.
Any questions comments from the mentoring team?
Anna did a really great job. We were happy to have her in the lab. Thank you, Anna.
Thank you.
In terms of research and student interaction, you have certain requirements in seminars, and they have to be seminars that you approve as accredited ones. So over the summer, the only accredited ones that we approve are for visiting faculty. So I know Mike Joyner was certainly one, and I can't remember whether we had any other non-UA faculty. So those seminars will count toward the requirements. And also, any of the seminars from visiting professors in the Sarga Heart Center, they'll be having like regular Friday ones, and those will also count.
Hi everyone, my name is Haley. I am a second year medical student, and I did my research with Dr. Worrell in the thoracic surgery. lab, and I'll be talking today about the effects of preoperative exercise on perioperative outcomes in lung cancer patients undergoing lung resection procedures. So a little bit of background. We know a lot about exercise and the various benefits that it's shown to have. This has mental, physical, and social benefits. It's been shown to help decrease rates of type 2 diabetes, to various cardiovascular diseases, to help improve the symptoms of depression and various other mental health disorders, as well as to provide a social community and improve self-esteem. In surgery specifically, exercise has been shown to help decrease morbidity and mortality, as well as to improve postoperative outcomes. With thoracic surgery specifically though, this correlation hasn't necessarily been shown yet, and so it has been shown that in thoracic surgery there is a benefit with exercise capacity, increased lung function, and increased strength and endurance, but it hasn't necessarily been shown that there are benefits in postoperative outcomes. So our questions we're looking at, does preoperative exercise improve those perioperative outcomes in these specific lung cancer patients undergoing lung resection procedures? And does it affect their hospital length of stay and overall survival rates? So we did a postoperative chart review of these patients, looking at all lung cancer patients that had a lung resection procedure at Banner from January 2022 to May 2024. This included a total of 148 patients, and they were separated into two groups based on self-described exercise activity. So this was strenuous activity as exercise throughout the day of high intensity. There were various things that patients described doing, including walking, running, biking, hiking, things like that. There were 52 exercisers and 96 non-exercisers in the groups. And to analyze the data, we performed a Wilcoxon rank sum test for our continuous variables and a chi-square test for our categorical variables. And after performing these analyses, our results showed that there was actually no statistically significant difference in those perioperative outcomes between the exercising and non-exercising groups. We looked at their overall hospital length of stay, as well as chest tube duration, any complications in the chest tube like ear leaks, recurrence of disease, as well as overall outcomes, so long-term survival and use of adjuvant immunochemotherapy. We did show that there was a benefit in the forced expiratory volume in 1 second of percent predicted in exercisers versus non-exercisers. So it was 95.84% was the mean in exercisers and only 87 in non-exercisers. So this does kind of align with the previous research that has shown that there is definitely a benefit in the lung function, but not necessarily a benefit in those post-operative outcomes like hospital length of stay and any complications that might occur. So based on this data, we can make some considerations and based on how we collected the data. So there's prior optimization that occurs in patients before they go into surgery. So all patients, they're tested and prepared for surgery to make sure that they have the optimal chance of survival and benefit from the surgery and to diminish any risks or postoperative complications that might occur. So with these patients, that can kind of make the exercising and non-exercising groups more equal because all of them are ensured that they're optimized prior to the surgery. Additionally, the mean age of the patients was around 70 for both the mid-70s for the exercising and non-exercising groups. And these are all lung cancer patients, so they have various symptoms, including things like shortness of breath, which can be exacerbated by strenuous exercise. So it's interesting that these could be limitations to the actual exercising in these patients, and that could equal out the level of exercise between the two groups. Additionally, this was a chart review post-operatively, so it was only based on what was in the chart for these patients, and some patients don't necessarily have all of this information in their chart. And it's also subjective statements from the patients about the kinds of levels of activity that they're doing, rather than something that's objectively measured from them. So this leads to a few more remaining questions. From the data that we collected, we included people that described things such as walking in their activity levels, but it'd be interesting, we want to take a look at whether strenuous exercise versus a normal exercise that's considered non-strenuous, so just daily activity, could have a difference in perioperative outcomes, so comparing those as well to the non-exercising group. And then also taking a more objective look at the data, so seeing if there is a difference in the type of exercise done, the duration, as well as the frequency of exercise to see if these affect the perioperative outcomes in these specific patients as well. So we're looking to do some future studies on that. We're currently doing some further data analysis on those strenuous exercises versus normal exercisers versus non-strenuous exercise versus non-exercisers. as well as looking to see if we can collect further data with some more objective measurements, including those data like type, frequency, and duration of exercise. And then in addition to this work, I also was performing some work collecting surveys for preoperative GI quality of life in lobectomy patients. So we're seeing if there's any effect on gastrointestinal quality of life prior to lobectomy and then 3 months post-operation. So we're using the GI QLI survey, so we've been collecting that from new patients in clinic prior to their surgery, and then we'll be continuing to do that, taking in all new lobectomy patients at Banner, and then doing a 3-month follow-up as well, just to see if there's any effect on the GI quality of life with that procedure because of the connection with the vagus nerve. So these are my references that I used throughout. I'd like to thank Dr. Worrell as well as the team in thoracic surgery that I got to work with, and I appreciate all their support and mentorship throughout. Any questions?
So I might have missed it, but what population did you look at? And then in the future, would you want to expand the population? And if so, how?
Yeah, so this came from a large database that we made of all of the patients that underwent lung resections, any form of lung resection here at Banner. So it was a single institution specifically here, and it was from those dates that I mentioned, and it was only, so it had a collection of all of the patients that underwent the lung resection, and then we removed the patients that underwent lung resection that were then diagnosed with something like sarcoidosis or cocci, and we only looked specifically at the patients that had lung cancer, and then that was the population that we analyzed for this data.
He's not here. Okay.
Do you have any comment?
I mean, yeah. Basically, it's hard to expand our population because it's patients who underwent cancer surgery. So it's just whoever shows up with a lung nodule and the CT scan, and that's what we got. But we enjoyed having Haley working with us over the summer. She did a fantastic job.
Okay.
Hello, for those who don't know me, I'm Johnny Yusuf, a second-year medical student, and my project was a secondary analysis of data sets involving invasive lobular cancers imaged with breast CT, and my mentor was Dr. Srinivasan Vedantam in the medical imaging department. So just a little bit of background before I jump into my question. So invasive lobular carcinoma, or ILC, is the second most common invasive cancer. And it's only second to invasive ductal carcinoma, IDC, which originates in the duct as opposed to the lobules. And the interesting thing about ILC is it often tends to grow in a single file strand as opposed to the more traditional lump structure. And so it results in an irregular and poorly marginated tumor, which is difficult to visualize on imaging and will often be missed. So it leads to patients presenting at a more advanced stage when they do come in. And actually a study comparing the 5-year survival rate between ILC and IDC patients found that ILC patients have worse 5-year survival rates, even though they have the more favorable biologic and phenotypic characteristics. And currently, the gold standard for detection and evaluation of ILC is MRI, but that leads us to the issue. So a study looking at how well an MRI estimates tumor size when compared to the pathology measurements found that specific to breast cancers, found that the MRI on average overestimates the size by about 0.63 centimeters. And that exaggeration is even more pronounced when you look at tumors of larger size. It goes up to 1.06 centimeter of overestimation for tumors that are greater than 2 centimeters.
So what that leads to is a lot of ILC patients, so tumor size plays a big role in determination of what treatment plan is gonna be made for the patient. And when a tumor is above 5 centimeters, the surgeon will often elect to perform a full mastectomy as opposed to a breast conserving surgery. And there are studies that show that ILC patients are more likely to undergo a mastectomy rather than breast conserving surgery when compared to IDC patients. And there actually a separate study showed that having a preoperative MRI increases the likelihood of a mastectomy. And that kind of goes back to having that overestimation of tumor size. So it is evident that there is a need for a better preoperative imaging modality, and that leads us to my question here, and it's how does dedicated breast CT compared to MRI in ILC tumor size estimation? And so what we hypothesized is that with CT will be superior to MRI in size estimation simply because it has better spatial resolution. And what spatial resolution is basically how much detail an imaging modality can see. And with CT, the voxel dimensions are smaller than an MRI, so it allows for much greater detail, and you can see things as small as 220 microns with a CT, which is why we thought it might be a better alternative to MRI when visualizing ILC tumors. And just a little bit about the process that we undertook. So what we did was we retrospectively analyzed images collected in a clinical trial led by my PI at the University of Massachusetts, Dr. Vedantam. And what they did is they prospectively enrolled patients with pathology-confirmed ILC and had them undergo both a contrast-enhanced breast CT and an MRI, with the CT being the experimental modality and the MRI being standard of care. And so what we did is we measured the dimensions of tumors on the reconstructed CT images in three orthogonal views: sagittal, axial, and coronal, and created a spreadsheet. All MRI measurements of the tumor sizes were extracted from the original radiology report, since that is the standard of care, so we just took that from them. And the pathology measurements were extracted from the corresponding pathology reports. And we do have some preliminary data here. So the graph that you see on the top right there is just simply looking at the correlation between the CT measurements that we took and the MRI measurements. And it shows that there is a good correlation there. But the more important graph is the one at the bottom. And what that one is showing is correlation to the pathology reports. So the blue line on top is the CT lesion measurements compared to pathology, while the orange one is the MRI measurements. And what we see is the blue line has a y-intercept that's closer to 0 and a bit of a steeper slope, which suggests that the CT measurements correlated better with the pathology reports than the MRI. However, just looking at this, there is going to be a need for further studies to confirm that, but it is promising. But as far as our project, the next step is to do the statistical analysis. So what we plan on doing is taking the proportion of tumors within 0.5, 1, and 2 centimeters of pathology report for each imaging modality, and then doing a McNamar test to analyze any differences and find if there's any statistical significance in that. A few fringe benefits of using CT over MRI as well is that it bypasses a lot of the traditional limitations that MRI has. The biggest one being length of the procedures. CT is a much quicker imaging modality, could be a lot more available. And then also patients that might have metallic implants or are claustrophobic that are not able to do an MRI scan might have potential benefits using a CT scan instead. And a few questions that remain. So if CT does indeed prove to be a better modality than MRI, what we're thinking is, does non-contrast CT estimate tumor size better than contrast-enhanced CT? And the reason we're thinking that is because, as we all know, with tumors, angiogenesis occurs to nourish the growing tumor. And with contrast enhanced CTs, but if those new blood vessels are gonna enhance, so if it's on the rim of the tumor, we're thinking it's gonna cause a false exaggeration of the tumor size. So the theory is with non-contrast CT, we might get a more accurate estimation of the tumor size that correlates with pathology reports even better. Another question that we had is, can CT become a screening tool as opposed to simply a diagnostic tool? And currently we use mammograms for that, but the issue with mammograms is that there is breast compression when that's done, which can be uncomfortable for a patient. And there is potential for tissue overlap, which can affect the visualization of a tumor. And those problems can be bypassed by a CT. And then lastly is how well are axillary nodes visualized with dedicated breast CT. Since we are looking at invasive cancers, there is the possibility of it spreading, so we want to make sure CT can visualize any axillary node spread as well. And a few plans for the future. So for the non-contrast CTs compared to contrast-enhanced CTs, we actually already began that. We have the non-contrast CTs from the clinical trial in Massachusetts as well. So we're doing tumor size measurements on that and adding it to our spreadsheet for analysis the same way. And we are looking at whether we can see the pectoralis muscle in those CT images to see how deep into the breast we can visualize. And as far as looking at the CT as a screening tool, Dr. Vedantam, the PI of the study, is planning a clinical trial that will analyze the efficacy of a new prototype dedicated breast CT machine, see whether it's a potential screening tool as well. That is pretty much it. Any questions for me?
So, like, MRI is used, like you said, like that's the kind of gold standard,
Mm-hmm.
and you guys are looking at CT, but
Yeah.
CT transmits like radiation.
Mm-hmm.
So, is your lab like looking into kind of like the cost benefit there, because like exposing a possible tumor more radiation?
Yes, so actually that's the dedicated breast CT machine that they're developing. Currently, where they're at with the technology is it gives about 3 months worth of natural radiation. So it's not a super crazy amount of radiation, but it is still a risk. And they are still working on developing new technology in the machines itself. That's more so on the biomedical engineering aspect to try to reduce the radiation as much as possible and make it, as safe as they can. But that is something the lab is working on. I'm not specifically involved in that, but it is a concern that they have in mind.
Something that's never asked about is the discomfort of the patient. Having had a few of these tests, I can tell you there's nothing more discomforting than the MRI for breast examination. Not only is the claustrophobia, the position you're put in for the period of time, and for me, it was second only to labor. It was really a very, very uncomfortable study that I wouldn't have ever again. Sometimes mammograms, with positioning and everything is comforting, but I think somehow there should be a question asked of patients about the subjective experience of the study. And I suspect CT will be less discomforting.
That is the hope.
Contrast. So it's certainly a question worth asking that is almost never asked. And I think
Definitely.
for me, it was a deciding question.
Yeah.
It was really uncomfortable. And I'm kind of stoical about pain and discomfort, so to get me agitated and say, take it off, stop the study, it was really very uncomfortable. And I know other people who said the same about the MRI for breast examination. You're lying in the stomach, it's a very uncomfortable, the whole thing's very uncomfortable.
Yeah, that definitely would be interesting to see, some patient reactions. And the hope is CT will be a little more comfortable in that sense.
Okay, thank you very much. I hope as you hear these presentations, you realize the variety of things going on in students' minds and activities. As a teacher really, they're all the same, and you're giving them the same answers in the lectures. But when you do the summer program or you do research, you really have an individual opportunity to show your individuality and your interest, particularly because the electives have been so reduced. It used to be that the whole senior year was elective, and quite a few faculty we fought to retain those elective times for the students, which for me at NYU, everything was elective in the senior year. And now we make it all these short blocks of things that everybody has to have, but they really don't have to have at all, you know. And I think the research distinction track and what you show here is how you exercise your individuality and even have some fun with questions, you know, showing funny questions on a dice and a die and so on. That you're playing around with your curiosity, you're enjoying your curiosity and so on, which is really the goal, one of the goals of the program.
Well, hi everyone. My name is Sabrina Secret, and my PI for this project was Dr. Sama Patel in sleep medicine. And our project has been focused around cardiorespiratory interactions in sleep-related breathing. So just some background on what we're studying, which is primarily OSA, or obstructive sleep apnea. So OSA is a series of apneas and hypopneas that occur during sleep. So either completely interrupted breathing or breathing that's reduced during sleep. That's due to physical obstruction of the airway. So people who are affected by this, about 20 to 30% of males in the United States and 10 to 15% of females in the United States are affected by sleep apnea, and the frequency of this only increases with factors such as obesity, increased age, and a smoking history. And so some treatment options, they're pretty well known by the public, are CPAP, BiPAP, and some other positive airway pressure devices. So I have a picture of that on the next slide, but it's just a mask or like a nasal cannula or something that someone will wear that pushes air into their system that can overcome collapses. And so why we're studying this is because it's associated with a lot of comorbidities such as heart failure with either preserved or reduced ejection fraction, coronary artery disease, arrhythmias such as AFib, aflutter, etc., sudden death, and then lengthening and shortening of QT intervals on EKG. And so something really important to know is that untreated sleep apnea causes a 2 to 3-fold increase of risk of all-cause mortality. So untreated obstructive sleep apnea is deadly. So it's something that we want to look at. I just want to talk a little bit about the methods of this project next. So like I said, this is a picture of just one of the models of a CPAP machine. There are many different models nowadays. There are even some devices that go in the patient's mouths that are a little bit more comfortable. But yeah, there are a lot of different models. So the method is a retrospective study, and we're doing data collection from Cerner patient charts, Banner patients who have underwent sleep studies. And we are extracting all sorts of data from their charts. So this includes like their apnea-hypopnea index. It includes their past medical history. So those factors that I was talking about, right? So smoking, heart failure, asthma, all these different things. We're also looking at their labs closest to their sleep study. We're looking at their echocardiogram. So all of these things, I've been going into REDCap, which is a survey database, entering those, just going between Cerner and REDCap. So here are some of the questions that our lab has, and this is definitely not a full list. So on your left-hand side, we're looking mainly at the difference between BiPAP and CPAP. So the first question says, are bi-level PAP modalities associated with greater QT variability and prolongation compared with CPAP in patients with OSA? The second and third questions are super similar. The difference is if we're studying CPAP or BiPAP. And we're looking at patients with and without heart failure with a reduced ejection fraction, and we're seeing if increased CPAP and BiPAP pressures will affect QT prolongation in these patients. And then the questions on the right are a little bit different. They have more to do with sleep stages and that interaction with QT variability. So the first question is impact patients without heart failure, so no heart failure present at all. Do we have a different QT variability in REM sleep versus baseline? Do we have a different QT variability in non-REM sleep versus baseline? And then we also wanted to look at the difference between the change in QT variability in patients with reduced ejection fraction heart failure or with preserved ejection fraction. So we're still collecting data for all of the questions on your left-hand side, so I've kind of shaded them for now. And we have been able to answer a couple of questions that are on your right-handed side. So I've included the answers in green and some of the p-values so you can see. So we did find a significant difference in REM sleep versus baseline in terms of QT variability. And so that p-value was 0.0026, and we found that there was an increased QT variability in REM sleep. When we looked at non-REM sleep versus baseline, we didn't find a significant difference there in QT variability. However, when we looked at patients with reduced versus preserved ejection fraction who used high PAP pressures, we found that patients with reduced ejection fractions they experienced significant changes in their QT variability compared with those who have preserved ejection fractions. So just looking at the graphs here, I included for our significant differences. So the first graph shows the p-value and significant difference for REM sleep compared with like baseline sleep and QT variability there. And then the second graph, the orange line is patients with preserved ejection fractions. And then the blue line is representing patients with reduced ejection fractions. And then we have our p-value there with the significant difference between the two groups' QT variability overall. And so, like I said, we still have a few remaining questions, and these were just the same questions that I had on the left-hand side of the slide before. And that's because this project is ongoing. We have the goal of bringing our data all the way up to the year 2024. And so far we have over 4,000 entries when I last checked, and then these previous studies when we ran the analysis, we only had, I think, up to maybe 2,000 in one of them, and then there were only like 200 or something in the other one. So we're looking to really build that database and then run more analyses. And the remaining questions, this is not the end of it. I mentioned a lot more factors that we're looking at, such as smoking and their labs and stuff. So we are looking into a lot of questions. This is not the only thing that we're looking at. And so here's just a timeline for what we expect in the future. So this summer, my team and I have been collecting data into Cerner, like I said. And then we're looking at about in August or December, we want to start writing up an abstract and a manuscript. And then in the February-March period, we're hoping to have our analyses done and see kind of what we observed in those studies. And so I want to thank my whole team, including my mentor, Dr. Salma Patel, and then the third-year medical student on my team, Carolina. She's amazing. She answers all my questions. We have an undergrad named Misty, and then we have a fourth-year medical student named Neil, and they're all amazing. So thank you guys for listening, and let me know if you have any questions. Yeah.
So you mentioned there's like different types of treatment. What's the difference between CPAP and BiPAP?
So CPAP stands for continuous positive airway pressure, whereas BiPAP is a bi-level positive airway pressure. So CPAP, you're only able to set one pressure, and that applies whether the patient is breathing in or out during sleep. And then BiPAP, the physician is able to figure out during the titration study that they can set two different pressures. So they set an inspiratory and expiratory pressure on the machine. So that's the difference. Yeah.
I was interested to know if you guys were also looking into central sleep apnea.
Yeah, we are looking into central sleep apnea as well. We are documenting if they have obstructive sleep apnea, central sleep apnea, or some people actually have a combination of the two. The focus right now is on obstructive just because that's the most common, but we will be running the analysis and see if we do find anything with patients with central sleep apnea as well.
I would recommend that all of you listen to Michael Graham's Graham Surgery three-year screen. But he's focusing more on all the behavioral interventions. Just was a remarkable presentation and review of the research and the interventions. So we would count that, although we usually don't count any grand rounds as seminars, but we would designate that particular one because so much research was presented there. Okay, that. Great one. Don't let you jinx anybody.
Hi everyone, my name is Geethika Amaneni, and this summer my project looked into the effect of increasing fluency of low-level laser therapy for treatment of androgenetic alopecia. And I had the privilege of working with Dr. Jedlowski, who's an incoming Mohs Fellow in the Department of Dermatology. So here's some background on androgenetic alopecia, also known as AGA. You might have heard of it as male pattern baldness or female pattern hair loss. And it's a common form of hair loss in both men and women. In fact, it occurs in 80% of Caucasian men and 50% of Caucasian women by age 70. It's a genetic disorder that's caused by an excessive response to androgens. And here's a brief overview of the hair cycle. This might be a review for a lot of you, but there's 3 phases: anagen, catagen, and telogen. Anagen is the growth phase, catagen is the transitional phase, and telogen is the resting phase. In most healthy individuals, most of their hair spends almost all of its time in anagen. However, in those with androgenetic alopecia, more of their hair starts to transition into telogen and spend more of its time there in that arrested growth phase. And that whole process is called progressive hair miniaturization. Their thicker pigmented hairs, which are called terminal hairs, are converted into thin hypopigmented hairs, which are called vellus hairs. And again, that's due to that excessive response to androgens. These vellus hairs are a very important target in hair growth therapy because once they fall out, that follicle is considered dead and regrowth is very unlikely. So we want to target these vellus hairs and convert them back into terminal hairs if possible. Androgenetic alopecia presents differently in men and women. In men, they tend to have a receding hairline and thinning at the crown. However, in women, they have more diffuse hair loss and they have preserved hair at their frontal hairline. And you can see better in these images, men are staged according to the Norwood scale and women are staged according to the Ludwig scale. Although AGA is considered more of a benign condition, it does have psychological impacts on those who struggle with it. Many of those affected suffer from feelings of anxiety, helplessness, and diminished self-esteem, and that can affect their overall body image and quality of life, which is why it's important to invest time and energy researching this condition, especially if it could improve the quality of life in so many that struggle with it. One of the current treatments for AGA is topical minoxidil, and it works by binding to ATP-sensitive potassium channels and hyperpolarizing that membrane, which then leads to a shorter time spent in telogen and more time in anagen. And some side effects include facial hair growth, hair shedding, and scalp irritation. And some more rare side effects include lightheadedness, flushing, tachycardia, headache, and blurred vision. And these more rare side effects are due to the vasodilatory mechanism of this drug. There's another commonly prescribed medication called oral finasteride, which is a 5-alpha reductase inhibitor. It impedes the conversion of testosterone to DHT. And side effects of this drug include decreased libido and erectile dysfunction. And some more rare side effects include gynecomastia, depression, increased risk of prostate or breast cancer, as well as testicular pain. So the side effects of these drugs can be quite bothersome to patients, which is why it's important to continue developing new therapies. As of 2007, a new therapy actually became cleared by the FDA called low-level laser therapy. And this originally began as a treatment or an experiment by a Hungarian physician in the 1960s. He was testing the carcinogenic potential of these lasers on mice, and he found that as an unexpected side effect, these animals had significant hair growth. This new treatment is termed photobiomodulation, and the predicted mechanism of action is that this low-level laser therapy causes the dissociation of nitric oxide from cytochrome C oxidase in the mitochondria, which then increases proliferation, cell metabolism, and tissue oxygenation. And you can see that a little bit better in this image. As you can see, the low-level laser therapy infiltrates that hair shaft and hair follicle and promotes cell metabolism and converts that vellus hair back into a terminal hair. So with this new treatment, there are, of course, a lot of companies who are going to want to profit off of that. And one of the first companies that created a laser cap is the original laser cap. And this is directly from their website. It's just a few characteristics of the cap. It uses a 650 nanometer wavelength laser, and it uses pulsed wave emission. One thing I want to emphasize is this cap and other caps like it are cleared by the FDA, which means it's safe to use, but it has not been FDA approved. Approval from the FDA requires studies in both safety and efficacy, and unfortunately there haven't been any high quality studies talking about the efficacy of this cap, which is where we come in. My mentor, Dr. Jedlowski, decided to reach out to this company and ask if they would provide us with caps so we could evaluate the efficacy of them on our patient population. So the goal was to basically see if there was a difference in efficacy between the low intensity cap and the high intensity cap. As you can see, there's a significant price difference between the two, so we want to make sure if we are encouraging patients to buy them that it's justifiable for the cost. So this led to the development of a double-blinded, placebo-controlled clinical trial. And our questions that we were asking within this trial are, does the higher intensity or higher fluency laser cap device result in a greater increase in hair density than the lower intensity or lower fluency device? And also, because we are including placebos in the study, we want to see if the laser cap is an effective treatment for AGA versus the sham device. And our hypothesis, I just want to go back to this slide to talk about the main differences between the low intensity and high intensity cap. The low intensity uses a lower energy dose and has a lower coverage area, whereas the higher intensity uses a higher dose with a higher coverage area. So because of that higher dose and higher coverage area, our hypothesis is that the higher intensity cap will result in greater increase in hair density than the low intensity cap. And I also want to quickly talk about our inclusion criteria. The main things we were looking for are, of course, patients diagnosed with AGA, but we also wanted to make sure they were untreated from any other hair growth treatments, just because we wanted to make sure any effects that were seen at the end of the study are solely due to the laser therapy. We also are looking for patients who are in those intermediate stages of hair loss, because once their alopecia progressed too far, they had follicular degeneration, and that means that that hairs could no longer grow in those follicles. Then this is also our exclusion criteria, but I'm just going to move on for the sake of time. And then we also have our demographics. Our goal is to get to 50 participants, and we're currently at 44. And out of those 44, 21 have fully completed the study. So we have 21 pre and post-treatment results currently. And then we have 23 males and 21 females enrolled. And here's some more information about the demographics stratified by race and whether or not they're Hispanic or Latino. And then here's just a flowchart of our methods. So once we've determined that the patient fits the inclusion criteria, we start taking some baseline data. So the main things that we're looking at are their global scalp. So we take photographs of their scalp from different angles, and then we also take close-up images of their hair follicles. We also ask them to complete a survey asking about how their alopecia has affected their quality of life. Then we randomize them into the three groups, the placebo group, the high intensity, and the low intensity group. And then they use the cap for 6 months every other day for 30 minutes. Then they return, and we do the same thing that we did at the baseline visit. We take those global scalp photographs, hair follicle photographs, and we ask them to complete the survey once more. So this is an example of those hair follicle photographs that we take. Thankfully, we have a software that's able to analyze them and take the target area hair counts, as well as hair diameter. We unfortunately have been having trouble with the software lately, so I don't have that data analyzed today, unfortunately, but hopefully by the end of the summer we'll be able to. And then this is just an example of a patient who had pre-treatment and post-treatment. And then this is an example of the global scalp photography. We do frontal, bitemporal, and vertex views, or vertex photographs. And the way we analyze this is we ask a dermatologist to assess the grade of clinical improvement that they see based on these photographs. And then the data that I do have analyzed today is the quality of life surveys. So the name of the survey is called Skindex 29, and there are basically 29 statements that each patient needs to rate on a scale of 0 to 4 on how much it bothers them. And 0 is actually the highest possible quality of life score, and 116 is the lowest possible quality of life score. So when we analyze these results, all the patients in the low intensity CAP group, we saw that 7 reported an increase in quality of life. And in the high intensity group, we saw that 5 participants reported a quality of life. But then when we ran paired t-tests, we found that these results are not statistically significant. However, something to keep in mind is we don't have all of our data yet. We only have the 21 participants who have completed the study, so we're still waiting on the full 50. The goal of this study is to hopefully determine if there's a difference in efficacy between the low intensity and high intensity caps. Because if we do see an improved response with the high intensity cap, then that shows that there is a justifiable cost for the price difference between the two. However, if there's no significant improvement between the low intensity and high intensity caps, then we might suggest the patients use less expensive devices, and that would benefit society by limiting healthcare expenditures. There are some minimal side effects with this cap. The most common one reported by our study participants was warmth without pain or tenderness, but they could potentially also have dry skin, pruritus, scalp tenderness, headache, skin pain, etc. However, no severe adverse events have ever been reported from these devices. And our remaining questions that I'm interested in looking into in the future are, would extending this study beyond 6 months lead to a continued increase in hair density and growth, or is there a point where these effects plateau? And also something interesting about this treatment, low-level laser therapy, is that it was developed to be used in combination with minoxidil and finasteride. So it would be interesting to see how the efficacy of low-level laser therapy differs when used in combination versus when each treatment is used individually. And that's all. Thank you. Are there any questions?
When you guys took the pictures of the hair follicles, did you do it on the same part of the scalp every time, or kind of every? Or
Yes, that's a good question. We tried to standardize that, and what we did is we looked at the vertex of the scalp for each patient and measured 1 centimeter to the right of it, because that tends to be the area where most people have hair loss. And we basically marked off a 1 centimeter area, and we shaved that area, we dyed it, and then that's when we put the trichoscope on there to take those phototrichogram images.
Is your mentor?
I was just gonna ask, what's the point of having the 2 types of caps? Like, would there ever be a reason why one would be preferred over another, or is it just, to have the price difference per se?
Yeah, that's a good question. So according to the website, they recommend the low intensity cap for those who have less intense hair loss or less extensive hair loss, and the high intensity cap for those with more extensive hair loss. So I guess an interesting thing we could do is maybe stratify our patients by the stage they are within their hair loss, and see if they had more of a benefit depending on which cap. But yeah, currently the main difference between the two is just the amount of energy they emit and how the company kind of recommends it. But that's a good question.
Is your mentor here?
He's on Zoom watching.
Oh, okay. Are they connected in or any reason?
Sorry, Dr. Fung.
Sorry, interesting study. So I have a question. Was there any attempt at blinding either the participants or the people
Yes.
analyzing endpoints? And which endpoints do you think would be most affected adversely by their some limitations?
So the study was double blinded, so the patients were not aware of what cap they got, and also Dr. Jadlowski was unaware. However, since I was the one kind of enrolling them and performing the exit visits, I was aware of what cap they were enrolled in. And I think there are some, it's a little bit, I don't know, it's interesting to analyze the data, like knowing which group each participant was in. But I think it's also necessary to have at least maybe one person who knows so that they can analyze that data. But we did try to make it as blinded as possible.
So the placebo cap, I was curious. Couldn't
Oh,
have
yeah.
been wildcat cap, right? So
Yes.
Or do you just not look it up or turn it on or like what do you do?
So the placebo cap looks very similar to the other caps, but it's kind of obvious if you have the placebo because there are no lights emitted, or the light that is emitted is just not the same wavelength at all, because 650 nanometers is red light. So both the low intensity and high intensity caps are red, but the placebo cap is not red. The light that emits is just like normal white light.
It would be interesting, did you ask people what cap they thought they had?
Yeah, we would ask them when they come back just out of curiosity, and sometimes they predicted correctly, but a lot of the time they were incorrect actually. They thought they had the placebo cap, but they actually had the low intensity, so that was an interesting thing to ask.
Thank you.
We had the issue after some of the early HIV trials where the patients would actually share their medications. So at least they got half a placebo and half therapeutics. I mean, that was very common early on in those trials. So I suspect it also occurs in other trials as well, but I suppose this one, we're not going to have it.
Yeah, many of our participants actually know each other because they would refer each other to this program. But it would be interesting to know if they like exchange devices ever. Thank you.
Hi everyone, my name is Grace Behrens. I did this work in the Funk Lab with Dr. Janet Funk this summer. The title of my project was the effect of extranuclear estrogen signaling on bone in an ER-positive breast cancer bone metastasis mouse model. So just a little bit of background. Breast cancer is the most commonly diagnosed cancer in women worldwide, and ER-positive is the most common subtype. The majority of patients who go on to develop metastatic breast cancer, bone is usually the first site, and again, the majority of these breast cancer bone metastases are ER-positive, around 80% of them. So because of this high association between ER positivity and bone metastases, there may be significance in the fact that bone is estrogen responsive. Estrogen is pro-osteoblastic. It increases bone density and promotes bone formation. This is why women who are postmenopausal and have low levels of estrogen lose bone density and start to develop osteoporosis. So although estrogen is pro-osteoblastic, most breast cancer bone metastases are osteolytic. And in the case of ER-positive breast cancer, it's actually, we think, the estrogen receptor signaling that drives tumor-induced osteolysis. So estrogen is the fuel that drives ER-positive breast cancer. So estrogen binds to its receptor, and this activates transcription and gene expression, leading to tumor growth. The cancer cells then secrete osteolytic factors that activate osteoclasts, and then when the osteoclasts resorb the bone, they release growth factors that further drive tumor progression. So it's kind of this cycle of osteolysis and tumor progression. So this may be part of the reason why ER-positive breast cancer has such a high predilection for forming bone metastases. There are also several different types of estrogen. The two that we're interested in are E2 and E4. E2, or estradiol, is the predominant form. It's what most people think of when you say estrogen. And then the other one over there is E4. This is a fetal estrogen. It's only produced by the fetal liver, so it's only detected in pregnant women, and then the levels shortly return. They return to undetectable shortly after they give birth. And it was discovered in the 1980s. We still don't know what purpose it serves. And then there are several components to estrogen receptor signaling. The genomic signaling is what most of us know. When estrogen binds to its receptor in the cytoplasm, it travels to the nucleus and activates gene transcription and gene expression. But there's also a membrane-bound estrogen receptor that is responsible for non-genomic or extranuclear signaling. And E4 actually lacks this extranuclear signaling part. It only has the nuclear signaling. So this is data previously published. This is data previously published by the Funk Lab investigating E2 versus E4 to try to elucidate the role between nuclear and extranuclear signaling. They used a tumor-bearing mouse model in which they supplemented mice with either E2 or E4 and inoculated them with human ER-positive breast cancer cells. They did find that E4 does not support ER-positive bone metastases. So on the left is osteolytic lesion incidence on X-ray. So you can see that blue line at the bottom. There was no radiological evidence of osteolytic bone metastases in mice that were treated with E4 alone. And then on the right is histologic tumor in bone area. So although breast cancer cells were detected histologically in the bones of mice, the area was much, much smaller. So because E2 supported bone metastasis but E4 didn't, this suggests that estrogen receptor extranuclear signaling is required to support ER-positive bone metastasis progression. And then they also looked at the effects on the bone itself. So on the left is bone mineral density of the proximal femurs, and the bone density of mice treated with E2 was significantly higher than the age-matched control. And then in E4 treated mice, the bone density did increase, but to a lesser degree. And then on the right is osteoblast number in the tibia, which significantly increased in response to E2, but did not change in E4 treated mice. So the observation that when extranuclear signaling is absent, there is decreased osteolytic bone metastasis formation and decreased bone anabolism kind of begs the question, what is the role of extranuclear estrogen signaling in ER-positive breast cancer bone metastases? This was the main question that we wanted to investigate this summer. Is it true that extranuclear estrogen signaling is needed for bone metastasis progression? And if so, is it a tumor effect or a bone effect? So the experiment done this summer was redesigned from the last one that I previously mentioned to be more clinically relevant. The last one, the mice were young and still growing, and they also still had their ovaries. So in this new experiment, we used mice that were skeletally mature, and half of them were also overoptimized to simulate menopause, as ER-positive breast cancer is most common in postmenopausal women. Additionally, we wanted to make sure that the E4 dose was enough since the half-life is so short in mice. So instead of an oral pellet, they were given implanted with a continuous pump of E4. And then they were injected with the human breast cancer cells and imaged weekly to monitor osteolytic bone metastasis progression and bone density. And then this is just a picture of what it looks like on the bone densitometer. I measured the proximal 25% of the femurs, which are tumor-free, and just because bone metastases tend to go around the knee in mice. So this gives a more accurate representation of what E4 and E2 do to the bone itself. And this is what we found. This is proximal femur bone mineral density with percent change from baseline, from their baseline bone density to day 28. Day 0 is the day that they were inoculated with the human breast cancer cells. So the green line is mice that were overoptimized with no treatment, and you can see that the bone density doesn't change. But then when you give them E2, the bone density increases, which is what we'd expect because estrogen is pro-osteoblastic. So the results that we found previously were still achieved in overoptimized and skeletally mature mice. And then here is when you give E4, and the bone density does increase, but not as much as with E2. And then we repeated the prior experiment from before with when the mice were not ovexed, but with our new experimental design of them being skeletally mature, and again with the continuous E4 pump. And again, E4 does not elicit as great a response as E2 does. So in conclusion, the data presented shows that both genomic and non-genomic ER signaling are required for ER-positive breast cancer metastasis progression. This suggests that the extranuclear signaling part may have a pathogenic role, as without it, tumor growth isn't supported. And then additionally, there is a reduced anabolic effect of E4 versus E2 on bone. So now, moving forward, we want to know if the nuclear versus extranuclear signaling is important in the tumor as well, on the tumor side of the bone-tumor interface. We're currently looking at the proliferation rate of the tumors harvested from the bone in the mice to characterize this more. And connecting the two conclusions, is bone anabolism important for tumor progression? Further understanding of this may lead to advancements in preventing and treating ER-positive breast cancer metastasis, which are currently incurable. I would just like to thank the Funk Lab for having me this summer and for their guidance. Thank you, Dr. Funk, and Amanda. Any questions?
Comments from Janet? Anyone else?
Great presentation. So we still have more work to do, obviously, and so what do you think, like, what could be clinical implications of this? Like, if bone anabolism is bad for breast cancer, in terms of supporting progression, is there any, like, should we use different kinds of anti-estrogens, or should women with breast cancer, a history of breast cancer, be given anabolic agents to treat osteoporosis? Or?
Yeah, if bone anabolism is bad for encouraging breast cancer metastasis, I wonder if there's like a way that we can like tease out targeting the estrogen receptor, because there's estrogen receptor everywhere. So if there's a difference in the estrogen receptors that are in the bone versus in the tumor, and we can target one more than the other, that may allow us to therapeutically treat the bone metastases without affecting the bone density.
Many of you have sufficient data to present at the Western Federation of Clinical Research as a major student meeting. The whole reason this meeting survives is because half of the presentations are from students rather than faculty. And that's in Carmel at the end of January. And I know it's begun to conflict with the step one exams, but I think you have some scheduling flexibility that the abstracts are due. When is the due date, sometime in September. It's coming up, so you may want to prepare that. The dean does pay for any student with an accepted abstract to get you travel and stay here. So I recommend that strongly. It's also a published abstract in the Journal of Investigative Medicine. Also, there'll be, in a few months, around the abstract submissions for a conference, and I'm involved with the Cancer Metastasis Through the Lymphatic System, which is a conference that occurs in San Francisco. It's actually a year from October, but we're going to have some early abstracts. And that is an international meeting. It's a great meeting. Sometimes you have the laureates there, but really top people in the cancer metastasis field. And a few of you are working in that area, and we have one investigative prizes and a bunch of other things at that meeting as well. I'll keep you posted. We'll try to keep you posted with upcoming meetings with some of your abstracts. And if you're presenting, you have to be presenting at the meeting to be eligible for travel. You can't just do a program.
Hello everyone, my name is Ariel De La Cruz. This summer I worked in the Johnson Lab in the IMD department under the mentorship of Dr. Michael Johnson. And the title of my presentation is S. pneumoniae carbohydrate utilization dictates macrophage-mediated phagocytosis. So Streptococcus pneumoniae is a gram-positive opportunistic pathogen, and the at-risk populations that it primarily affects are children, elderly, and the immunocompromised, and it can cause significant morbidity and mortality in these populations. There are over 100 known serotypes, which are all characterized based on their polysaccharide capsule. So the pathogenesis of pneumococcus is, first it colonizes the nasopharynx, and from there it can be transmitted to other hosts via shedding through respiratory droplets or coughing, sneezing, and from there it can invade and cause disease. Some of the common diseases that it causes is pneumonia, bacteremia, meningitis, and then it can also cause local spread and otitis media and sinusitis there. So the purpose of my project this summer was to study carbon source utilization. So basically, different carbon sources are present in different anatomical sites of the body. So in the bloodstream and in the CSF and in different fluids in the lungs, like the alveolar lining fluid and interstitial fluid, there's glucose, which is the predominant carbon source that the bacterium will use. In other sites, like the nasopharynx and also a little bit in the lungs, there are different carbon sources. So these carbon sources are compose mucin, which is a component of mucus. And the carbon sources present in mucin are galactose, N-acetylglucosamine, and mannose. And the three that I studied this summer, did experiments with this summer, were glucose, galactose, and N-acetylglucosamine. So this is some data previously generated by a grad student in the lab, serotype-specific carbon source dependent growth. So on the left, you have a bunch of different serotypes, both encapsulated and non-encapsulated pneumococcus strains. And then on the bottom, it's different carbon sources that were tested. And so basically, the dark purple signifies like large max growth, and the white or light purple signifies low max growth. And this was done over a period of 60 hours. And basically the takeaway of this heat map is that max growth is carbon source dependent and serotype specific for each strain of pneumococcus. So my main question this summer was, how does the carbon source utilized by Strep pneumoniae affect macrophage-mediated clearance? And this is the question I was seeking to answer throughout my experiments that I performed. So the cell lines that I used this summer were only Tiger 4, which is a major invasive encapsulated serotype of pneumococcus, and its unencapsulated derivative T4R. It's the same genetic background as Tiger 4, it just doesn't have a capsule. And capsule is important because it plays a major role at the pathogenesis of pneumococcus, as it's made by virulence factor. It is made up of carbohydrates, sugars, and it surrounds the bacterial cell wall. It helps the bacterium escape phagocytosis by inhibiting opsonization, and complement activation provides a physical barrier to engulfment, and it also helps the bacterium resist intracellular degradation within the macrophage. And so we also used macrophages. And macrophages are important because they're important in the innate immune response to pneumococcal infection. So the macrophages used were raw 267.4, and we just seek to understand if the clearance of the bacterium was affected in our subsequent experiments. So our experimental design, you can't quite see all of the words, but basically I plated, it took a while to optimize because this isn't a technique that is commonly done in the lab, but we finally were able to land on some solid ground, and it worked pretty well. So basically I would plate to raw 264.7 macrophages and a 12-ball plate, and then I would wait for them to adhere and recover overnight, around 16 hours. So the following day, we would infect the macrophages with either Tiger 4 or T4R grown in host-specific carbon sources, which were the glucose, galactose, or N-acetylglucosamine. And from there, we would spin them down to initiate the co-culture and then incubate them together at different time points. And after the incubation step, we would wash with gentamicin for around 10 minutes to kill the extracellular bacteria. And from there, we would lyse the macrophages and plate the recovered intracellular bacterial CFUs on blood agar plates and count those. And that was the readout of our data. So here is one of the first experiments that we did. It shows macrophage-mediated clearance of bacteria grown in glucose. So plotted is the recovered CFUs per mil in log scale of the experiment, and then at the bottom you'll see the two different serotypes. So unencapsulated is T4R and encapsulated is Tiger 4. So as you can see, there's a significant difference in recovered bacteria for each time point, from 0 minutes, 30 minutes, and 60 minutes. And throughout each time point, there was more encapsulated bacteria recovered. There's also a trend of more phagocytosed or engulfed bacteria over time. So this chart shows macrophage-mediated clearance of bacteria grown in different carbon sources, so glucose, galactose, and N-acetylglucosamine, which I previously mentioned. The same thing is plotted. It's recovered colony-forming units per mil. And basically what this is showing is sort of the same result, but in a slightly different way, because we only use the 60-minute time point for our subsequent experiments, because that was the time where they were able to engulf the most bacteria. And so what this shows is that in each carbon source group, there were more encapsulated bacteria recovered. And then the difference was most pronounced in the galactose group. So my conclusions for this data is that there's increased recovered bacteria with increased co-culture time. As you saw in the first graph, this is true because we found more bacteria over time. Also, encapsulation versus non-encapsulation does influence macrophage-mediated clearance, and carbon source growth conditions of bacteria may impact macrophage-mediated clearance as well. So the clinical implications of this work are a few. So first, it can help us understand the pathogenicity and virulence. So by understanding the carbon source utilization of pneumococcus, we can maybe learn the metabolic needs, what they need to grow more, to thrive, and we could possibly target those pathways. We could also possibly develop novel antibiotics to target these mechanisms. So if we know that it needs a certain carbon source to thrive, we could possibly inhibit the uptake of that carbon source through an antibiotic. And then also improving vaccine development and developing ways to improve the efficacy and make a stronger immune response to vaccines. And then also enhancing clearance by macrophages.
So the macrophages, as I said before, are a key component of the innate immune response for clearing bacterial infections and investigating how carbon source utilization of pneumococcus impacts its susceptibility to macrophage-mediated clearance may lead to novel immunomodulatory therapies. So my future directions for this project are to increase biological replicates, just to make sure that the data is more robust, to add another component of mucin, which is mannose. It was a little bit difficult to grow the bacteria in mannose, which is why we weren't able to do as many experiments. So just optimizing that a little bit, and then including more encapsulated serotypes and non-encapsulated isogenic derivative strains. And then also to repeat with different macrophage cell types. So bone marrow derived macrophages or tissue resident macrophages as well. And then finally, to analyze pro-inflammatory cytokines and sepsis biomarkers would be something that I would like to look into further. So my final question after this summer doing this work is, how does carbon source utilization of S. pneumoniae impact pro-inflammatory cytokine secretion by macrophages? And this is what I would like to look at next. So I would like to give a special thanks to the Johnson Lab for all of their help this summer, especially Dr. Michael Johnson, who was instrumental in my progress, and he provided me with a lot of guidance and support and all of the resources of the lab. I'd like to thank Fadi, who is a PhD student in the lab, because without him, I wouldn't have been able to do a lot of the experiments. He has very vast expertise in bacterial culture. And then I'd like to thank MSRP for everything you all do, and then our funding for the summer. And I thoroughly enjoyed all of the opportunity to do this work and continue broadening my research skills. So thank you, and are there any questions?
So you had the heat map earlier. So is glucose just the one that bacteria just across the board?
Yeah, so glucose is the preferred substrate for the bacteria, which is why you can't grow bacteria without a carbon source, carbohydrate source, because it needs nutrients to grow. It needs carbohydrates to grow. So glucose was essentially our control group, because it's the preferred substrate for growth.
Elementary group, is your group here?
They're on Zoom. They're
Okay.
streaming it in lab meeting.
Actually, the pneumococcus is more important for something much bigger than all the experiments that were done on it and all the diseases that are caused by it, because it is responsible for the Human Genome Project, because it was experiments demonstrating that the transforming principle in the capsule of the pneumococcus, which was extracted from empyema in healthy patients, was just sugar. Because at that time there was a real controversy that a sugar could not possibly contain the stuff of heredity. It's too simple. It had to be a protein. And it was the pioneering work of a group at Rockefeller and at NYU Bellevue, which demonstrated that it was a sugar. And they never got the Nobel Prize for it. It's a more important discovery than the helix. But the pneumococcus in the capsule was very important in demonstrating that. I have a special interest in it because you recall on my plot, I asked how much spleen do you need to protect against post-splenectomy sepsis. The commonest organism in causing post-splenectomy sepsis is the pneumococcus, the encapsulated pneumococcus. And what the spleen does that no other organ can do is it creates non-specific opsonins, which actually allow for the phagocytosis. If you don't have antibody, if you haven't been exposed to the pneumococcus before and you don't have a serotype that is an antibody specific for it, you will die if pneumococcus gets into your bloodstream. In a fulminant way, in 24 hours, you can see on a blood smear the pneumococcus throughout the blood. And there's really, at this point, no treatment by the time the patient comes in extremis. This is post-splenectomy sepsis. And our work was to look at how much spleen you needed to protect. It took us 10 years, but the answer is a third of the spleen. If you have a third of the spleen and it's vascularized, It's not spritzed out because sometimes you get splenic injury, pieces of spleen get all over the peritoneum. And there was a theory that these born-again spleens would protect, but they do not protect adequately. That you need a vascularized spleen. And that led to the whole field of splenic preservation, how much you preserve, how you preserve press and everything. So there's a lot of interesting things around the more topics in addition to the area that you're exploring.
Thank you.
The scientific adventure about this is called the transforming principle. It's incredible. It's well worth reading how the discovery was made and how it's which is so needed. Like this whole idea that sugar could be discovered the rest of it's unacceptable to chemists.
Okay, so hi everybody, my name is Ali Sheikh. I am working with Dr. Kuo at the U of A's Arthritis Center, and I'm going to be talking about using our whole knee multi-view approach to quantify fusion synovitis in knees with osteoarthritis. So the first question that we have to answer is what osteoarthritis is exactly. So osteoarthritis is a whole joint disorder. Causes symptoms such as pain, stiffness, loss of function, and swelling in the patients that have it. And some of its pathological traits include a loss of cartilage, osteophytes, but other traits such as bone sclerosis and remodeling bone cysts. And there are a lot of risk factors for osteoarthritis that can cause someone to be more likely to have it. Some of these include someone being older, being female sex, having an injury to the joint, or some genetics. But other risk factors that can cause someone to be more at risk for osteoarthritis, such as obesity and a lack of exercise, have actually been increasing in the US over the past few decades. And this is also one of the reasons why osteoarthritis as a condition is relatively prevalent not only in the US, but also worldwide. So in speaking in terms of globally, there are over 500 million cases of osteoarthritis in the world. And in 2019, 365 million of those cases were specifically knee osteoarthritis. And this comes with a lot of challenges. So clinically speaking, there aren't any FDA-approved treatments yet for preventing disease progression or stopping or slowing disease progression. And most treatment currently is focused on symptomatic control, such as using NSAIDs for pain management or inflammation management. And economically, there's also a burden as well. Over $128 billion was lost in the US in 1 year alone due to osteoarthritis-related issues. One of these issues, for an example, would be people with osteoarthritis, like I mentioned before, experience a loss of function. So they won't be able to do their jobs, which results in those lost earnings. Next up, we want to understand how osteoarthritis is actually evaluated. So radiographic knee osteoarthritis is defined as the formation of osteophytes, or these bony outgrowths, and or joint space narrowing. And we use something called the Kellgren-Lawrence grading scale for this. And we can see in comparison grade 1 to grade 4 that the joint space has narrowed over those 4 grades, and that there is some bony outgrowths, at least for the grade 4 knee. And there's been a growing understanding that knee osteoarthritis is an entire joint disease. It doesn't just involve the bone, it involves the soft tissues, the cartilage, and all of those features that can't really be seen on x-rays, which is why MRIs have been emerging as a better medium for evaluating some of these soft tissue structures. One of these being effusion synovitis. So this is just a combined term of effusion or fluid and synovial inflammation or synovitis. And this trait specifically has been linked with radiographic osteoarthritis and a loss of cartilage, as well as eventual knee replacement. So this is something that is important to look into, at least when evaluating osteoarthritis. And currently, effusion synovitis is assessed by experts on a semi-quantitative scale, but the problem is that there comes some limitations with using this process, because you need the experts to be able to do the assessment, you need the expertise that comes along with it, and it's also not a score that lacks granularity. which brings us to our lab research. Our overarching lab question is our approach, our multi-view only approach to evaluating effusion synovitis both reliable and predictive for future disability? There's a long-term goal that comes along with our lab research, which is to facilitate targeted interventions to slow the progression or to prevent osteoarthritis as a whole. So how do we do this? Well, we randomly selected 50 patients' knees with osteoarthritis from the Osteoarthritis Initiative, which is a longitudinal cohort study. And with our approach, this allows for a real-time cross-plane quantification of effusion synovitis via our dual view system. And I'll go into what that looks like in a little bit. And effusion synovitis on non-contrast enhanced MRIs, which is what we use, looks hyperintense, so bright white. And it's these hyperintense areas within the joint capsule that is quantified and added to our complete volume of effusion synovitis that exists in the knee capsule. So this is what that dual view system looks like. We have something called the axial view and the sagittal view. So the axial view is essentially a cross-section of the knee, and you can see some of the features such as the kneecap, the femur, and some muscular structures as well on the axial view. And the sagittal view is essentially looking at the knee from the side. So you can see more of those longitudinal structures such as the ACL, which may be a little easier to see on that sagittal view. This is what our setup looks like for answering our main question. So it's a setup of 3 different monitors, with our left and right monitor showing our axial and sagittal views respectively, and our center monitor being where all of the main work happens. So a closer look at our center monitor shows that for this person, they were likely working on the axial view. You can see at the top those red shaded areas. That's what effusion synovitis is shown on that axial view. And while they're working, they can also see that there's a sagittal view on the right and near the bottom, so it allows for that real-time cross-plane quantification of effusion synovitis. So why does that even matter? So there are some advantages for having a dual view versus over a single view. One of these being able to tell the difference between an artifact versus an anatomical finding. So I have an example on the right here, and for a non-expert or a trainee that isn't super experienced with MRI structures or radiology in general, they wouldn't be able to tell whether this black line is actually an artifact or and something that's part of the anatomy. And an artifact is just something that shows up in the image that isn't actually there. So for the purposes of this example, this is something called a plica, basically just a folding within the knee lining of the joint. So for non-experts and trainees, they wouldn't be able to necessarily tell the difference between this and just an artifact. And this allows for our non-experts and our trainees to have a much more accurate quantification of effusion synovitis and get a better idea of the fluid that is actually there versus something that isn't there. Our data is analyzed using something called an interclass correlation, and this essentially is something that measures the reliability and the correlation between clustered data that's sorted into groups. And with this, we get something called the ICC, or the interclass correlation coefficient. All this means is that if the ICC is close to 1, then that means that there's a high correlation, high degree of similarity between 2 different sets of data. If it's close to 0, then there probably isn't any correlation or any similarity. And this is an example of data from our lab. You can see on the x-axis that this is our trainees' quantification of effusion synovitis in the 3 different views in comparison to our experts' quantification of effusion synovitis. And for this data specifically, the correlation was relatively high, with the average ICC value being 0.996, so very close to 1, virtually identical almost. Which is something that is interesting to see. And with our future steps, we want to delve a little bit deeper into how our dual view compares to our sagittal only segmentation. I talked a little bit about the advantages with regards to artifacts versus anatomy, but it would be interesting to look into more of the quantitative comparison between a dual view versus sagittal only. And our other question that we would like to ask in the future is, how does the quantitation of effusion synovitis change over time? For example, something that we would be interested in looking at for this would be to quantitate the volume of effusion synovitis in patients at their baseline, then after a 1-year follow-up, and then after a 2-year follow-up, and see how that changes with their disease. And I also want to give a thank you to Dr. Kuo and all the members of our team that have been a great help to me over the past summer, as well as all of our friends over at the Arthritis Center as well. Are there any questions? Please let me know. Yeah.
If there's no way to prevent disease progression right now, is there an importance for early diagnosis of osteoarthritis?
There is. So one of the reasons why we would like to try and catch those patients while they're in the early stages of osteoarthritis is so that we can direct them and enroll them in clinical trials that are already working on this issue. And this allows us to have a better understanding of which clinical trial therapies work best for progressing or for preventing progression of disease or slowing disease progression.
Any mentoring team present?
Yeah, they're back there.
Do you have any comment? Anything you want to make?
Yeah, so I think that one of the things that people may not realize is that inflammation is becoming increasingly recognized as being important in osteoarthritis by work that we and others did, and some of the older physicians may recognize that it used to be that osteoarthritis was the quote non-inflammatory control when they studied rheumatoid arthritis, and so we realize now that actually it's not as severe as what you see in rheumatoid arthritis in terms of red, hot, swollen joints, but it's actually a very important component in osteoarthritis, particularly knee osteoarthritis, and it's increasingly a target for treatment. So in terms of treating inflammation, also in terms of other treatments that may grow cartilage, but if you have inflammation there that's not treated, it doesn't necessarily make a difference if you're going to grow cartilage because it's not necessarily going to grow in a good environment. So this is important, but one of the things that our lab is doing is to try to do this in a much faster and quantitative fashion, because if you do the semi-quantitative, it only takes about a few hours for an individual to read the various different features. So this really, the idea is to speed this up and also then to use non-expert readers, which would be much less expensive to do this. Ultimately, in the future would be, and we're working on this, is to use artificial intelligence and deep learning to automate this process.
Any other questions? Please not. Next person.
Good morning, everyone. I'm Michaela. I work under Dr. Zoe, Chief of Vascular Surgery, for this summer, but I will be talking about medication adherence in post-operative vascular patients today. So a little bit of an overview of my presentation. I'll go over some background information and then talk about a retrospective study done under my mentor this past year, and then talk about the prospective study that I'm working on right now, and then I'll briefly go over some next steps with you guys. So when I talk about post-op vascular patients, I am encompassing adult patients who undergo any of these interventions listed here. So one of my initial questions was, what are the common complications that happen after this procedure, and how would you manage them? So there's things like bleeding, clotting, infection, but for my project we're more focused on the treatment that is given for the clotting aspect. So these are some of the treatment guidelines for that. Patients are given post-operative medications to take after their procedures. So another one of the questions I had was, which of these meds are given in what scenario and why? So most patients are given the aspirin and the statin, and then people who are at higher risk of atherothrombotic events, for example, if they had stent placements, they're also put on this P2Y12 inhibitor. So an example of that is clopidogrel. For instance, if a patient gets a carotid artery stent, they were put on a dual antiplatelet therapy, so they're given the aspirin and the clopidogrel about a month, and then after that they're on the aspirin indefinitely. But these medications are really important because they prevent any cardiovascular morbidities that happen after surgery, so things like MI, stroke, blood clots or ischemia, things like that. But the issue is that not all patients that are prescribed these meds are compliant to this regimen. So a little bit about the retrospective study that I talked about. Dr. Zoe, my PI, Daniel, he is a vascular surgery resident at the U of A, so he's also helping with the prospective study right now. But basically, major results from that study, all patients who were taking their medications for up to 6 months post-op continued to take them up to 9 and 12 months as well. And then there was a lot of causes for non-adherence, but patient-related causes tends to be the most influential. So from that study, they found that new adverse drug reactions was the most common reported barrier from the patients. And then there were also history of adverse drug reactions, pharmacy restock issues, knowledge gaps, and perceived therapy ineffectiveness and memory lapses. So the question from this is, how do we work to improve the rate of medication adherence in these patients? So that brings me to the prospective study that I'm working on right now. So basically the idea with this is that we're trying to make a standardized survey that we give to the patients post-op, and then we will call the patients serially over 12 months and then go over this survey with them. So we're going to call them at 1 week post-op, 1 month, 3, 6, 9, and 12 months post-op, and then go over the same survey with them each time. So the phone call kind of serves like as a reminder for them to take their medications, and then in that way we can evaluate, if any, what barriers to adherence they're experiencing if they're not able to take those medications, and then hopefully we can implement an intervention to help them with that. So this is just a few screenshots of the survey that we're working on. I think the hardest part with making the survey is how to include everything that we want to include in it, but also make it really concise and simple, just to keep in mind that we're giving it over the phone and things kind of seem like a little more confusing, a little longer over the phone than it is in person, as opposed to if you're reading it and hearing the information in front of you. So this first page here is a lot of demographic information. We included things like main mode of transportation, just because that's a really common and well-known cause of like a barrier to healthcare in general. On this survey, which is not on here right now, we have a food insecurity screening form, just because one of the questions that we have is, how does food insecurity or living in food desert affect medication adherence? Because there's not a lot of research done on that, especially with this patient population. So we include all this demographic information just to serve as like future avenues for possible research projects. And then this page on the right, aspirin adherence summary form, there's a page like this for each of the 3 medications. So the phone counselor will go over this form every time during each phone call. So for example, if I'm calling someone and they tell me that they're having trouble taking their statin because they're not able to get a refill from the pharmacy, then I can contact Daniel, who's a resident, and then he could see if he could do something to help that patient, and hopefully that intervention will increase the rate of medication adherence in that patient. But basically the main question that I'm asking for this project is this survey efficacious in improving the long-term compliance of post-op meds? And then with that, our main goal is to improve patient care in that way. And then some next steps to finish the survey, which is pretty much done already. And then we can continue on with patient recruitment, phone counselor recruitment, and then in between working on grants as well. Some references. And then any questions?
So I'm just curious, how are you measuring like long-term improvement of medication adherence if you're intervening in all the calls? Like, is there a placebo group? Like,
So we thought about having a control group for this study, but that kind of just limits our patient population by law, because we want to have a target of like 100 patients with intervention. So we're thinking about using the retrospective study kind of as a placebo. So we use the rate of adherence for that one since it was just published about like less than a year ago, and then compare that to our patient population for the study. Thank you.
I think we lost a connection or something. It's up here, but it's not up there.
Maybe you can close it. Or change it. Okay, so my name is Ria Arvind, and this summer I looked at changes in Goutallier score and cross-sectional area of rotator cuff following surgical repair. This is a prospective pilot study, and it's an observational study as well. And my PI is Dr. Michael Feldman, an orthopedic surgeon here at Banner University, and my mentor is a resident in orthopedic surgery as well, Dr. Spencer Knight. And so before we talk about the rotator cuff, which is the main muscle group that we're looking at in this study, I wanted to talk a little bit about the shoulder joint, and which is also known as the glenohumeral joint, and a little bit about the anatomy of that. So the shoulder joint is classified as a ball and socket joint. So the glenoid fossa is kind of like this rim, and the head of the humerus sits on the glenoid. And that allows for a lot of mobility in that joint. It's almost like a golf ball that's sitting on a tee. And with that mobility, there's a big risk of stability. So you're compromising stability to get a lot of mobility in this joint. And so that's where the rotator cuff comes into play. It's 4 muscles. You have the supraspinatus right here, the infraspinatus, the teres minor, and then on the other side you have the subscapularis muscle. And so the function of these 4 muscles is mobility, but also a great degree of stability. And so when you have any sort of pathology in these muscles, you're going to sacrifice the stability of that joint. So that's just a little bit of background. And so what do I mean by pathology of the joint, of the rotator cuff? So there's a wide spectrum of things that could go wrong with these muscles, from impingement, tendinopathies, partial rotator cuff tears to full thickness rotator cuff tears, which is kind of the end of the spectrum and the worst outcome. And when looking at research, age is the most prevalent risk factor for developing rotator cuff pathology, as well as pain in the contralateral shoulder. So there was a study done at University of Washington in 2018 in which they had 2 groups. One group that had no shoulder pain and one group that had shoulder pain in one shoulder. And in that group, the above age 66, 50% of that group that had shoulder pain were also likely to have pain in the other shoulder. So that is a big risk factor. Having one pathology in one shoulder can contribute to pathology in the other. So that's where fatty infiltration comes in. So Goutalier's score is kind of the way that we measure fatty infiltration. So following a full thickness rotator cuff tear, the muscles retract from their attachment, and because they don't really have a function anymore, they're kind of just hanging there, they become de-innervated and atrophy. And eventually this leads to fatty infiltration from adipose tissue surrounding the muscle as well. And the Goutalier score is developed by Dr. Goutalier in the late 80s and early 90s, and he came up with a sort of grading system that now radiologists use and orthopedic surgeons use to quantify the extent of fatty infiltration within these muscles. So there's grades 0 through 4, depending on how much fatty infiltration is in the muscle. So grade 0, which isn't shown here, is no fatty infiltration. Grade 1 is normal fatty infiltration. So this is a T1 weighted MRI image, and so the hyper intense, like white, is showing fatty infiltration. So in normal, there's 10% of the muscle is covered by fatty infiltration. In grade 2, there's 10 to 50% of muscle will be covered by fat. Grade 3 is 10 to 50. Grade 4 is 90% or more. And grade 5, which is kind of a new subset of grade 4, is when there's more fat than muscle. And at this point, the rotator cuff is deemed irreparable, and there's virtually no reversibility of the fatty infiltration. So while it's really clear that after a rotator cuff tear, fatty infiltration does occur, there are a few studies that have discussed and understood really what happens post-surgery to fatty infiltration. So theoretically, post-surgery, the fatty infiltration should reverse back to normal, and the cross-sectional area of the muscle should increase from the atrophy. And so, this is another T1 weighted image, and this shows grade 2 fatty infiltration in the infraspinatus and teres minor. So, like I was saying, there's very few studies that compare post-operative and pre-operative Goutalier score measures, as well as the post-operative and pre-operative rotator cuff cross-sectional area, as well as it's not really understood if the Goutalier scores can actually predict the degree of repairability. If like higher scores mean that it's the complications of the surgery are more, and that patients can't get back to their functionality that they were before they tore the rotator cuff. And so that's where Dr. Knight and we both were discussing this, and he came up with the idea of comparing MRI results from pre and post-surgical repair of rotator cuff and looking at changes in fatty infiltration as well as cross-sectional area of the rotator cuff. So the first question that he came up with are what are the changes in fatty infiltration and cross-sectional area of the rotator cuff before and after surgical repair. The first hypothesis we came up with is fatty infiltration and cross-sectional area will increase after surgery. And then the second hypothesis is that fatty infiltration and cross-sectional area will return to a state similar to that of the contralateral shoulder, which in this case was a healthy shoulder that we used as a control. The next question that we had is Goutalier's score and cross-sectional area able to actually indicate the repairability of the rotator cuff tear? And the hypothesis that we came up for this question was a higher Goutalier score, meaning more fatty infiltration, and a smaller cross-sectional area, meaning more atrophy of the muscle, can indicate irreparability and of the rotator cuff tear and more complications in surgery. And the last question was combining the objective data and the subjective data. So we looked at if Goutalier score and SPADI, which is the shoulder pain and disability index, were directly proportional. And the hypothesis here was that patients with higher Goutalier scores will report worse patient-reported outcomes and have higher SPADI scores, and overall a decrease in functionality and increase in pain post-surgery. And so how did we do this? For collecting objective data, this is a prospective observational study in which currently we have 7 patients enrolled, so it's a pilot study. We're hoping to get to 10. And the condition observed, as I said, is rotator cuff fatty infiltration and cross-sectional area after surgical repair for full thickness rotator cuff tear. And the way that we measure this is via MRI. MRIs were taken pre-operatively of the injured shoulder, and then 1 week post-operatively we took MRIs of both shoulders. And then the contralateral shoulder is a healthy shoulder that we used for control. And then 3, 6, and 12 months we hope to take MRIs of the injured shoulder after the surgical repair. And then we also collected patient-reported outcome measures. So we used 2 scales, the SPADI, which is a standardized shoulder pain and disability index. This has a pain and disability subscale. And then we used the ACES score, which is an American Shoulder and Elbow Surgeon score. This is a little bit more specific to patients who have shoulder pathology. And this was again given to patients pre-op and 3, 6, and 12 months post-op. 1 week, 3, 6, and 12 months post-op. So this is an example of the SPADI. As you can see, there's a pain and disability subscale. We had patients fill this out, rating 0 being no pain and 10 being the worst pain or disability imaginable. And this cumulative score is what comprises of the SPADI, and so we took that and we added them up and came up with those results. And then this is a little bit harder to see, but this is the ACES shoulder score, and that has pretty similar questions to the SPADI, but again, more specific for patients that have undergone shoulder repair and have shoulder pathology in general. And then this is another data research collection sheet that we gave patients. This is kind of a little bit more comprehensive and it has more demographic information that we collected. Handedness is is something that I want to point out because if a patient is right hand dominant and they tore their left rotator cuff, we're going to expect just naturally and physiologically a higher cross-sectional area in their right because they are right hand dominant. Past medical history is also important, diabetes here. Family history, past surgical history is important. We wanted to make sure we had patients that had isolated, full thickness rotator cuff tears and no other shoulder surgery. And that really kind of narrowed down our sample size and made it a little smaller because we wanted to make sure it was an isolated surgery and isolated tear. And then social history, smoking, tobacco, something that we wanted to make sure that we asked because smoking can naturally delay the healing process after orthopedic surgeries. So that brings me to study population. This is inclusion and exclusion criteria. We wanted to make sure again that it was a unilateral rotator cuff and a full thickness tear. So any partial tears or any other tendinopathy was excluded. And we also wanted to make sure the rotator cuff was repaired primarily via surgery. Exclusion criteria was any prior shoulder surgery in that shoulder, as well as any sort of symptomatic rotator cuff pathology or tears in the contralateral shoulder. And these are very preliminary results of our subjective data. This is the pain and the disability subscore. And for the most part, patients reported higher pain and disability pre-op compared to post-op. This data is very limited and our sample size is very small, and this is only post 1 week after surgery, so we still have to collect data 3, 6, and 12 months post-surgery, which hopefully will give us a more robust database and results. Again, this is SPADI. And then with our objective data, we're looking for MRI results again. So the radiologist will be double-blinded, and we will send all of the images without any labels, so they don't know whether this is preoperative, post-operative, how many weeks or months post-operative, and the radiologist will then computate using their own software the cross-sectional area, using the radius of the humeral head, as well as grading the extent of fatty infiltration in each of the images for both the healthy control as well as the pathologic shoulder. So that brings me to remaining questions. This data is not very longitudinal yet because we just started the project, and there will hopefully be we'll get to know some long-term trends in the fatty infiltration and the Goutallier scores and what their correlations are with functional outcomes using our SPATI and ACEs score. Another question that I was interested in looking at is how different rehab protocols and PT exercises could influence the changes in Goutallier score post-surgery. This would be interesting for outside of surgery and more looking at PT and different exercises that could increase the stability of the rotator cuff and maybe reverse the fatty infiltration that is seen after a tear. The effectiveness of Goutallier score assessment between CT and MRI imaging modalities with respect to diagnostic accuracy, if one over the other is able to grade the actual extent of fatty infiltration more accurately or not. And lastly, the impact of patient demographics like such as age or the presence of a contralateral tear and pre-existing health conditions on progression of fatty infiltration and effectiveness of surgery for repairing the rotator cuff. Yeah, I'd just like to say thank you, and here are my references. And then any questions?
You mentioned one of your exclusion criteria is contralateral shoulder pathologies like tears, but does that also include more chronic conditions like arthritis?
Yeah, so we did include patients that did have arthritis in their shoulder joint because a lot of our patients are older, and if they have any sort of pathology in their rotator cuff, they're more likely to also have less stability in the joint and have arthritis in their shoulder as well. So that those patients were included.
Do you know why patients that have shoulder pathology are more likely to experience it in the contralateral shoulder?
Yeah, so I think a lot of it, I feel like when I talked to Dr. Knight, he was saying a lot of it is that they start using obviously the other side more, and that could just cause like just overuse of the other shoulder as well. But yeah, that's something that is also really interesting. Should be. No, Dr. Feldman couldn't be here today.
She was the last one.
A couple of things. In order to get the credit to go into RDT, you have to complete all the requirements for MSRP and graduate, get your T-shirt and so on. And that means you have a 4-page report. You should have attended the seminars, and if not, if you missed some, then you need to make them up in some way. We'll make sure we do that. You have to complete your logs. So then you can convert it. If you've done all those things, then you can request conversion, get your mentor to approve that. And then you can start counting time, but you can't start counting time for RDT until everything else is completed. Okay? And then just a word, I noticed that most of you may not have even realized it, but you use the word hopefully. Now, hopefully is fine when you're talking about hopefully your patients are going to get better, hopefully the world isn't going to be fighting wars. But if it's hopefully relating to your hypothesis being correct, then I suggest you use, Claude Bernard was the discoverer of the experimental method. In effect, he said, leave your hopes at the lab door. You can pick them up when you come out. So try to avoid using the word hopefully if it's that you're going to get an answer, a positive answer, your hypothesis is going to be correct, or so on. So just be careful. But most of you did use that word. Do you recall using it, some of you? Because I was listening for it, and I'd say at least 5 of you, maybe more, use the word hopefully, but you were using it in relationship, hopefully my experiment's going to work out, hopefully, and so on. So it's just interesting that you might be sensitive about not using it. Okay. Are there any other questions you have about the program and the requirements and so on?